excited from the Green Mountain Care Board to be in St. Albans this afternoon, and I thought we'd start just by going down the table and introducing who we are, starting with you, Jess.
Sure, Jessica Holmes, and I live in Middlebury.
Maureen Yusufer, I live in Colchester.
And I'm Tom Pelham, and I live in Berlin.
Kevin Mullen, and I live in Rutland.
Robin Lunch, and I also live in Berlin.
Mike Barber, live in Huntington.
And I'm Susan Barrett. I'm the executive director of the board, and I live in Norwich, Vermont.
And before we get started, I wanted to recognize a few people, and this is always dangerous because you never know who you missed. But I did see, what I said to Jill was, this is the best turnout of any legislative delegation we've seen at any one of the meetings that we've done outside of the So hopefully we caught everyone. We believe that Representative Lisa Hango is here, Representative Brian Savage, Representative James Gregoire, Representative Mike McCarthy, Representative Sharon Fagard, Representative Casey Toof, Representative Barbara Murphy, hey Barbara, and Representative Lynn Dickinson. So thank you so much. And who did I miss? This is the dangerous part.
Someone might walk in later. So. Yeah, I think you did great.
Good job.
Good job.
Great. So this is good to see such a big response from the community, and we're really excited to be here today. We had a great morning. We had to split into three because, as the legislators know, we're subject to the open meeting law, so no more than two of us can be together as we go about our duties. So our general counsel was here to keep a close eye on us, to make sure that we behaved, and we got to learn a lot this morning. So the first item on the agenda is the Executive Director's Report. Susan Barrett.
Yes, thank you, Mr. Chair. And I'm going to take this opportunity just to tee up what we're going to hear today from the NMC staff. To let folks know first, we get out on the road a couple of times a year, and I believe we haven't been to every county, but we're getting close. We're up to about 6 or 8 so far. But we, as Kevin said, this morning we were out in the community learning about the work that NMC and the community providers are doing. The way we have framed today's meeting is we want to learn about how this community is implementing the Allpayer Model. For folks who aren't familiar with this is an agreement that the state of Vermont entered into in 2016. It is an effort to move away from fee-for-service episodic medicine to preventive and value-based care. And boy, did we see a lot of prevention this morning. I was over at the school learning about Rise Vermont at the city school. Yes. And I was dancing, and it was a blast. So no, it's just, it really, as Jill said, it warms our hearts just to see the work that's being done out there in the community. So it was a great experience. So we're going to take this the next step, and we're going to have presentations from Jill and her team, and they're going to be looking at the work they're doing in implementing the Allpayer Model. And we have 3 population health goals for the Allpayer Model that the state needs to attain, and those are reduction in deaths due to suicide and drug overdose, increase to access in primary care, and decrease and morbidity and mortality of chronic disease. So we really wanted them to frame their discussion around those 3 high-level population health goals. So I just wanted to tee that up and give you a little background. And I think I can turn it back to you, Mr. Chair, and then we can start the presentation.
Thank you, Susan. Before we start the presentation, we have one item of business that we have to finish up, and that's the minutes of Wednesday, October 2nd. Is there a motion?
So moved.
Second.
It's been moved and seconded to approve the minutes of Wednesday, October 2nd without any additions, deletions, or corrections. Is there any discussion? Seeing none, all those in favor signify by saying aye. Aye. Any opposed? So with that, we'll turn it over to Jill. And again, we're just so pleased to be here. And boy, you draw a crowd.
This is fantastic. So I know everybody knows me, but I'm Jill Bowen, CEO of Northwestern Medical Center. I've been here for 10 years, and it's really been quite an amazing ride. How you really engaging with the community, you can make really all things possible. So when I see all the people here, it really just tells me that this is a real community, and transformation can only happen if you have an engaged community. So there's so many people in the audience, and thank you for doing those introductions to our legislators that are working hard for us in Montpelier. You know, I think about the team that I have here at Northwestern Medical Center. There's so many of you, and the leadership team, our board members that are here. Also, I'll introduce one, Ted Tyler. He's actually the chair of our incorporators. So when you think about our whole organization, Ted Tyler is here, and also our vice president, Steve Marshall, is here as well. Our vice president of our board, Jan McCarthy, is here. Karen Rushlow is here. And other board members, John Cassavant is here, who's a board member as well. And I could just keep naming folks, and I'm just grateful to have such a sea in this audience. At the state level, Jeff Tiemann is here from the Hospital Association. Thank you for being here. And we've talked a little bit about Rise Vermont and about population health. And you know, Vermont is small enough, you know, to move the outcomes for the greater population. So the collective impact with Marissa Parisi and Alida Duncan is here as well, and to take this whole statewide with OneCare Vermont. So we're going to talk about partnership here in this community and how it's linked to the state through OneCare, and this is the way that we can mobilize a community. So I'm hoping I grouped you, but there's just everybody in the room I can just speak to in the difference that you're making in the care of Franklin and Grand Island, and the state too. So we're going to talk about Franklin and Grand Island. We're going to talk about the communities, accountable communities for health. This morning, getting that real look at those topics they discussed, like the suicide, the mental health, the addiction, and actually being right out at the sites and talking with the providers. I know we have providers in this room too. We have physicians in this room, which is fantastic, right? It takes a whole village to change a culture of a community. So let me begin by just refreshing us on what our priorities are that we're facing as a community. So a community health needs assessment, which we're all required to do, but it's what work we should be doing. And really finding out what the population needs and how we as a community can actually provide those. So mental health and substance abuse, you see suicide there as well. Even when you get into domestic and sexual assault, the visit to the ED, what we're doing for suicide precautions and how we're taking care of and assessing our patients no matter what door they come into, even into our community partners, and how we're wrapping around whatever door someone comes into. We're there for them and asking the questions that can help them on their way to better health outcomes. Obesity, we got a chance to talk about population health, and this really starts with our children and really changing the norms and the culture so our children are living healthy and they're teaching their parents and they're beginning that lifestyle and certainly a long life. And food insecurities and smoking and vaping. As you see, this list is all about behavior, right? This list used to start off with primary care and access to specialists. And now it's really switched to behaviors that we can wrap around as a community. So our strategic plan, so I'm doing a little bit of grounding, and I have great partners that are going to be presenting some of the detail. Over the past 3 years, you can see this is 2019, we're actively participating right now in developing our strategic plan going forward for the next 3 years. But it's going to look probably somewhat similar. It's really about integration. And when you think about primary care being the center of the healthcare delivery system, it still is, it still will be with the medical home and the blueprint, how we provide options both. And it's not all about, when I'm actually talking, I'm no longer talking about Northwestern Medical Center. I'm really talking about this community and how we've come together. Whether they're independent or employed, what is the right level of access for our community? and notch the federally qualified health centers and having actually a site on this campus and other sites across our communities, getting access available to our population. And then when your primary care isn't available, having the availability of urgent care, so that the emergency department is there for true emergencies. And we've done great work in this community through our partnerships to reduce those avoidable visits in our emergency department and getting folks where they need to be. With the emergency department comes the mental health. You've heard a lot about us certainly in the media about how we're taking care of our behavioral health patients. And we're doing an amazing wraparound, and we're getting our facilities to be able to wrap around and our emergency teams in place to protect our patients, to provide the best care as well as safety for our staff. So mental health and making sure we have access to the providers and our partnerships again with the Howard Center and NCSS and others. Specialty care services. You'll see this at one location at the front of our hospitals, and what is the care that is needed in our community, but maybe we don't need to have it full time, so having rotating clinics at the front. We do have full-time cardiology and pulmonology, but there are other services such as neurology and newly endocrinology that are on our campus, and also using telehealth. How do we get the care local? Because if the care is local, you'll access that care locally. And then surgical specialists, making sure we have the right complement of surgical care. And then what I call the zipper throughout this is really about population health and making sure that wherever we're touching the patients in the community, across our community, we're asking the right questions, we're getting to the food insecurity, for example, we're getting to smoking, we're getting to those behaviors, and so that we can wrap around as a community to really improve the population overall. So we like our pictures, right? So pictures tell so much for a story. And so the accountable communities for health, and what is our strategy as a community? And it's really about partnerships. And when you think about the tree, this was something that the state sponsored a few years ago, and then we took our partners and really talked about who are we and what is our infrastructure where we're providing care for our community. So we created this tree, and knowing that it's really about community partnerships that really are the roots to our community system, addressing those social determinants for health, such as housing, for example, transportation. And then that actually, the soil, feeding into the roots and into the trunk. And Rise Vermont, the Department of Health, where we're embracing healthy lifestyles and creating an environment where people can be successful. So when a primary care provider actually has a plan for you and you're healthy, we want to keep you healthy by having the environment, your communities, your schools, your workplace, everywhere, embracing these wellness policies so that we can actually thrive and live out our primary prevention strategy. And then the branches, primary care, really being the blossom, the flower to this whole community, making sure that everybody has access to primary care, and the blueprint where we're surrounding everyone with a community health team and access to the right services at the right time, bringing the care right to you. Our community has formed a regional clinical provider council, performance council, where the community comes together and talks about transitions of care. Or what are the priorities? We look at OneCare Vermont data, for example, and we say, what are some things that we should be looking at in the learning collaboratives that we have that fills rooms like this to talk about what is my role in that particular path for that type of patient or a type of experience. So we know what our roles are, and if a patient comes into our space, then how we link them up to that care path. So a community coming together, this room is full of folks leaning into the transitions of care. And with that, we formed the SUN here is the Unified Community Collaborative. Again, community members, a subset of the Regional Clinical Performance Council that forms a steering committee that really learns. It's a lot about education. What is the housing situation? What is about food insecurity? How should we allocate our resources so that we can benefit the overall outcomes of our patients and our connectivity as a community? The more that we're connected and doing the right care at the right place and the right time, and you think about capitated system and working together and keeping people well, we can best all thrive and survive in a system like that by really providing resources and really nurturing and guiding and growing this community together. Now with that, there is an amazing cultural transformation that takes place, where we're really trying to move folks to embracing healthy lifestyles, but we understand the world that we're in. And so how we make that shift, and when you think about the Rise Vermont and lifestyle medicine, it really is about a community coalition to embrace healthy lifestyles, to improve the quality of life, to reduce the cost of healthcare, where we live, work, learn, and play. And I'm going to turn this over to Karen Staniels. That's going to give us a little bit more detail of what that means.
Hi, I'm Karen Staniels. I'm one of the directors of physician services here at Northwestern Medical Center. I oversee orthopedics and rehabilitation. I also oversee occupational health, our employee health program, and our lifestyle medicine program, which includes our lifestyle medicine clinic, as well as diabetes, nutrition, and health coaching. I'm very honored today to show you 3 different programs that we've implemented to not only improve the quality of life of our patients, but hopefully to decrease healthcare costs, both in the short term and in the long term. The first of that is our surgical optimization program. It started about 3 or 4 years ago with our nurse navigator with total joint surgeries for orthopedics. Since then, it's blossomed into a much more structured and functional program where the patient who's undergoing surgery at Northwestern Medical Center has multiple ways to access services to help them optimize their health before surgery. We work on weight management, diabetes control, tobacco cessation, and blood pressure management. They can access the typical outpatient services like physical therapy and nutrition. They can see Dr. Fontaine at her lifestyle medicine clinic and be followed by a health coaching person. The nurse navigator will work with them telephonically, or they can join our new group, which just had its 1-year anniversary, our surgical optimization group. This is a free program for people who will have their surgery at NMC, where a trained facilitator works with them every other week on an educational component, and then through the group process, sharing goals and figuring out how to get over the barriers that's preventing them from meeting their goals so that they can have surgery. As you can see from this year, we're already having some great success. We're demonstrating better than average weight loss. The improvement in lab values for those people that have diabetes has been quite impressive. And I'm a physical therapist by trade, so I'm most impressed by the functional outcome scores. So those are standardized surveys that are nationally recognized that people take at decision for surgery, and then we continue to follow them at certain points through that. I believe most of these are at 4 months, and you can see we far exceeded our benchmark of wanting an improvement of 18 points. We're averaging about 29 points. And this last bullet is the one thing that we really want to see more of. We did have a person who came, had a significant weight loss, had an amazing result in improving her diabetes, and she felt so good she canceled her surgery.
Perfect.
What a success. The second pilot program we started with our own employees. At Northwestern Medical Center, every year we offer people free of charge for themselves and their spouses a health risk assessment, biometric screening, and health coaching visits. Unfortunately, this last year, we realized that 19% of the people who participated had lab values that suggested they might be eligible for a diagnosis of prediabetes. So we immediately offered those people the opportunity to see one of our certified diabetic educators. And unfortunately, only 19 of them accepted. However, those 19 had amazing results. They exceeded their weight loss goals, and they were making great improvement in their self-management goals. There's multiple studies out there that show cost savings of preventing somebody from progressing to diabetes. I used a very conservative study which showed about $2,500 savings in healthcare costs every year. For those 19 people, If we prevented them from going on to diabetes, we'd be saving about $50,000 a year. In a 10-year period, that's $500,000. What would be more impressive if those 100 prevented from going to diabetes, which then made our savings annually at $250,000 and a 10-year savings at $2.5 million.
Were you able to survey those 98 people that chose not to
We did
seek help?
informal surveys. They weren't very participating. We can find out why. There were a lot of people that just wanted to go talk to their doctor. And some people,
So it's not that they didn't follow up, it's just that,
most of them didn't follow up.
okay.
Most of them didn't follow up. I think there was some denial, and I think we have a lot more education pre-diabetes, both in our population and with our providers as well. So there's more exciting things that have happened with that as well. Right, so obviously a $2.5 million savings over 10 years for a company the size of Northwestern Medical Center would be quite significant. So this is something we're going to continue to work on. The last program I'll just briefly touch on is embedding health coaches in primary care. This was based off a model that has already been successful by embedding mental health, social workers, and care managers in primary care. We use the OneCare quadrants of care, with 1 being the healthiest people and quadrant 4 being the medically complex, to sort of delineate the roles between the health coaches, the care managers, and social services. Care management and social service workers tend to spend the most of their time with the sickest people, those with the highest social needs. The health coaches are working with the healthier people, people who are beginning to develop disease or have stable disease, who potentially could get better, but definitely don't want to get worse. You saw the savings from pre-diabetes. We can probably calculate out the same savings for high blood pressure, obesity, and all those other things. So again, investing in health coaching, investing in these preventative mechanisms such as pre-diabetes. Some of you know pre-diabetes isn't usually covered by payers. They'll pay for diabetic education. They won't pay to prevent somebody from getting diabetes. That's the system that's got to change. Health coaching, if we can get those people to optimize what the optimal self is and work regularly on those visions with their provider. We're primary care medical home, so we all set goals. This is where we hope that we can spend a lot of time and resources and have a majority of our successes. Thank you for the time. I was able to share just a few of the mini programs that NMC is doing. And now I'm going to turn it over to Denise Smith, who's going to tell you what we're doing out in the community.
Thank you.
Good afternoon. I don't need to speak into this, but I do like a microphone, so I might. So I'm Denise Smith, and I oversee the RISE Vermont program regionally for Franklin and Grand Isle counties. I help to set our strategic priorities with our executive committee, and I also work to support the rollout of RISE Vermont across the state, working with the OneCare team, the RISE Vermont team at OneCare. I want to thank you for the opportunity to speak today, for coming on the tour with us today and entertaining us a little bit. There is a video of the dance.
You might want to invite,
posted
Member Pelham to replicate his dance.
I didn't know I was being videoed.
We did a Halloween monster dance. So it was quite comical. I also want to thank the NMC Board of Directors, as well as the NMC leadership team, for giving RISE Vermont the opportunity to work with our community to create a culture of change, or a culture of health in Northwest Vermont. And also, I just want to recognize the people of OneCare. I don't know who's here today, but for really embracing RISE Vermont as the primary prevention strategy and partnering with us over the last 2 years now, I think we're walking into. And as well as Marissa Parisi, who's the Executive Director of RISE Vermont statewide, just really embracing the concepts and the ideas that we've really put forth in our community. I can change my slide. So RISE Vermont is a capacity building approach that's rooted in public health models. So it is great that we get to go dance with kids at schools, but there's reasons that we do that. And it's all really based on some behavior change theories that we've researched and gotten into. It's also creating across the state a systematic way of bringing health and well-being to other communities. We have a roadmap that we follow with all of our new program managers. We've embraced an international model called ECODE, which means Together We Prevent Childhood Obesity, as well as working with CDC, 24 Strategies. We use a collective impact model to work with our communities, make sure that we have diverse stakeholders at all of our tables. And we've embraced the socio-ecological model, which is the Vermont prevention model, really looking at the outer layers that support the individual in their community to change behavior. So it is about the health coaching, it's really about what Karen's doing in the hospital, but it's also about all those external factors that make a person decide what they're deciding to do for their health and well-being. And that's what we want to work at. And those are our platforms, our models that we follow. We track all of our results using a results-based accountability. And I want to just say, these are some of our highlights from 2019. And our work brings us into the classroom as well as at the policies tables. So it's bringing us at that level, grassroots, with the teachers in the classrooms, but it's also, we're sitting at policy-making tables. And one of our biggest coups or things that happened this past year was that we increased the WellSat score, which is a CDC assessment of school policies. It was at 33% to 82% in strength for all of Maple Run School District, which impacts about 2,000 children. So that's a lot of covered lives, as we like to call them in the healthcare industry. It's a lot of people. And so that wellness policy change is a huge shift that's going to impact all of those children, because what it means is that we're supporting healthy behavior change at the school level throughout. We've also, in working with the classrooms too, we worked with over 100 classroom, which impacted about 1,600 kids throughout Franklin and Grand Isle County. And then we track everything on a scorecard. So that's really, again, it's a well-developed change model that's evidence-based. And our scorecard we have at the school level, we have at the municipal level, and we also have at the worksite level. And the most important thing that I like people to know about the scorecard, because the scorecard kind of plays over, really what it means is that practice, when you get to that gold level, you're implementing, you're modeling, and your practices and policies in your system. And that's really the important thing about the scorecard that we like to know. Why gold? What's so important about getting to gold on the Rise Vermont scorecard? The other thing that I just want to show is that this past year, I asked the team to really think about, like, what is happening? What is this investment that Northwestern Medical Center is making in Rise Vermont, in our wellness specialists that are working in the community? And what is that actually translating to in dollars in the municipalities? And so we've turned ourselves to the fire starters, right? Because we're kind of the pot stirrers. We make things happen. We bring ideas. We're sitting at the table and we're really looking at things through that health lens, the health equity lens. And so what's happened is that little red bar is what Northwestern Medical Center is investing in staff time in the various communities that you see laid out there. The green bar is what communities, municipalities have invested in healthy infrastructure in their communities in just 2019. And the gray bar represents what they've done since 2014. And so what we're really seeing is just having a fire starter, somebody who's coming to the tables, who's going to select board meetings, that's talking to planning commissions about what they could be doing differently, is actually sparking change and creating investment at the infrastructure level in the municipality, which is where we want the municipalities to be spending their money. I just want to touch on, because this is sort of new data that was just audited by UVM's research faculty and statistician. Last year in 2018, we did an active play campaign And again, like it was a 9-month campaign. It focused on getting people out and moving. We did a lot of social media posts. We did a lot of interventions, competitions. We had a Playscriptions booth going around a lot of events. The key behind this, we have midterm indicators, and one of them is we want to, and this is Vermont Department of Health language, so I apologize. It's a complicated thing, but decrease the percent of adults with no leisure time physical activity, which actually translates into we want people moving more when they have free time, right? That's what we want to do. And so we use the behavioral change model theory of trans-theoretical theory, stages of change, to implement the campaign. We did a pre and post survey, so we surveyed people before and after the campaign. And it was the survey was put out by the Vermont Department of Health as well as Northwestern Medical Center. Rise Vermont had nothing to do with the pre and the post. We shared it. And what we found was that there was statistically significant changes in the data points. So what we can infer from this data, and this is what my researcher told me to say, so I'm going to read this so I get it right. We can infer from this data that the active play campaign increased both people's change of value, so they valued active play more. It was a change in the number of people who self-reported being more active than their peers, as well as people that self-reported that they increased their participation in physical activity. So it worked, which is really exciting. I'm going to pass it over to my boss because he's going to tell you what we're going to do next. Jonathan Billings.
Now I have to figure out which one to speak and which one to push. I'm Jonathan Billings. I'm Vice President of Community Relations in Rise Vermont here at the hospital. And I just wanted to share with you just insight into where Rise Vermont is going here in Franklin County, and then talk to you about a couple of the barriers and opportunities that lifestyle medicine in Rise Vermont and prevention as a whole face as we head down this path. So our efforts in primary prevention are ongoing and high energy. School wellness policy. Denise talked about increasing Maple runs from 33 to 82%. We're now seeing interest from our other superintendents about bringing that policy wider, and we're seeing through statewide Rise Vermont, other schools around the state also intrigued by, hey, how do you do that? And so you'll see more work from us on that. Safe Routes to School is a long-rooted, if you will, effort here in the area, and we'll continue to advance that so that more kids are walking and biking to schools. Grants to amplify local projects. We invest through the Rise Vermont effort funding to fire start projects in the municipality, or to advance projects, or to be that final money that somebody has worked really hard to get their project going and they just need that last bit to finish it off and make it real. And so we've got a team that invests in the community to get those things going. The Rise Vermont team just completed their second measurement study of our first, third, and fifth graders in 100% of our schools throughout Franklin and Grand Isle counties to look at their healthy weights. And that's our long-term measure over time to see if we're changing the health of the community, with the indicator being the health of our children. And so the UVM researchers are currently going through that data, and we'll have our second data point on our path. Advancing active transportation. It's not just the kids that we want walking and biking to work. We've brought in national experts that have worked with our municipalities to make all of our communities more bikeable and walkable for adults as well. You'll see more of that. Community-wide challenges are great fun. That's the fun part of Rise Vermont, and that fun part continues. At the state level, all of the Rise Vermont initiatives have joined in the Sweet Enough campaign, and looking at how we reduce sugary beverages, not only for children, but also for adults, and looking at what healthy swaps are and how we can just pay closer attention to our calorie intake through some real easy changes. And you saw the statistically significant results of the Active Play campaign. We think we can make a meaningful difference in sugary beverages as well. The regional recreational collaboration continues, and that's a great grassroots effort here of all the various recreation programs of different sizes and shapes of all of our municipalities in Franklin and Grand Isle counties, Vermont has helped them come together and partner and share resources and share promotion. And so you see a lot more community ownership and partnership there. And then evaluation and dose calculation. Measuring what we're doing so we can report results to folks and show that we are indeed making progress towards our midterm measures, and our long-term goal is really important. And the dose calculation is a new term for us. It's a new piece of research that we've got a PhD student at UVM who is helping us with, is looking at how much of a good thing do you have to inject into a community to really make a difference. It's a really simplistic way to explain it, but I'm not the one getting the PhD. The challenge as we move forward is that we've got a real opportunity here to shift mindsets and to begin really valuing prevention and well-being. We will always value the medical work and treating the sick and healing folks, etc. And what we want to do is to elevate to that same kind of value, the work to get ahead of the curve and prevent things, both by being out in the community, creating an environment where people can be successful, and by being inside the medical community, working with our providers and helping them help our patients onto those paths. The challenges are society's cultural shift from managing disease to prevention and wellness is slow. The idea that our systems don't pay for pre-diabetes education when it's really efficient to do it, that's got to change. That's a slow change. People's mindsets that getting old doesn't necessarily mean that you have to have chronic disease. That's a slow change. For us in a really practical setting here, things like Rise Vermont is evidence-based that it takes 10 to 20 years to change that in a community. We live on a one-year budget cycle. We live on a 2-year governor cycle. Maintaining momentum is a challenge with those short cycles when you're looking at long-term indicators. And then in frankness and in a little bit of lobbying, there's insufficient reimbursement for prevention and well-being services. Things including health coaching and nutritional counseling, etc. We had a great discussion this morning about working with the insurers about shifting that fundamental insurance package to begin to include some of that so that when your doc says, hey, I do want you to be exercising more, maybe there's some help towards physical activity in your future as part of your health insurance, etc. And so those are the things that we're working through within the community. And I'm going to turn it to Amy Putnam to talk to you a little more specifically about the Allpayer Model and the Accountable Care Organization and what data we're seeing in there.
Great. Thank you. I'm Amy Putnam, and I am the Vice President of Physician Services here at the hospital, overseeing all of the outpatient practices for our organization. I'm going to take a few minutes now to talk with you about how all of this great work connects to the Allpayer Model. So what we know is that prevention and well-being are the right investments. We also know that it takes time to achieve the desired healthcare outcomes for population health. We also know that the traditional way of paying for healthcare services in a fee-for-service model will not work as we embark on really transforming clinical systems redesign in our community. So how are we partnering with our key stakeholders, with the Blueprint and OneCare, to take the work that they're doing with payment reform and connect that to the work we're doing here in our community to really change the way our systems are redesigned. Many of us are familiar with Mark Friedman's model for results-based accountability. So what we pay attention to is the things that, what are we doing differently to achieve different outcomes? How much of that are we doing? And is anyone better off because we're doing all of these things? So in our community, the amount of funding that's coming in that's separate from the fee-for-service, the way we've always paid for healthcare, the new money coming in are basically in 3 different categories. The first one is the Blueprint's Community Health Team funding. This funding is directly attributed to primary care's patient-centered medical home. So the amount of that money is specifically determined on the size of the panels within primary care. We don't have any way to really adjust that right now. The second is OneCare's Vermont Care Coordination Model. That's just about $537,000. This money comes into our community directly related to the attributed lives within the methodology for the Allpayer Model. Again, very specific people that we are able to attract and spend these dollars on. The third is the other funding. There is a multitude of different funding in this category. One is the blueprint and the ACO capacity payments that come in under paid per member per month, monthly payments to the practices. It also includes money that practices and providers are individually and personally investing in new resources. It's also grants, and with NMC, we had a budget reconsideration a few years ago that allowed NMC to invest certain monies in primary prevention as well as lifestyle medicine and Rise Vermont. So we could do different things with this money that we can't do with fee-for-service dollars. Under the OneCare Vermont Care Coordination Model, you know that we can spread that across the community. It's not just primary care that's servicing these patients, the families, and very vulnerable populations. It's our partners with our designated agency, Northwestern Counseling and Support Services, Franklin County Home Health, our area aging, and other really important stakeholders. So all of this money pooled together really equates to about 42 FTEs in this community. And that's multidisciplinary FTEs. They come from different disciplines such as social work, counseling, RN care coordinators, dietitians, nutrition, many of the things you heard earlier, and most recently health coaches embedded in primary care as well as our lifestyle medicine clinic. So what are we doing to measure the value of all of these FTEs? One of the measures that we're using is OneCare Vermont's penetration value of 15% of the attributed lives and how many people are we reaching for care coordination. Our health service area has achieved the 15% for our attributed lives. We know that there are more than that because that's the counted attributed lives under the Allpayer Model, but there are certainly more than that. Under the Blueprint for Health, we know that money, we have to service the panel for primary care. Under the OneCare Care Coordination Model, we service the individuals that are attributed to that Allpayer Model. One key opportunity that we have in this area that we really have to spend time on in the next year is incorporating our non-ACO members. We know that the social determinants for health are really critical to patient engagement in changing their health outcomes. Employment, transportation, housing, food insecurity. If people are not able to come to their healthcare appointments ready to have the personal resources to spend on that, then they just can't do it. So it's very, very important that we incorporate many stakeholders in the community and not just the medical providers and medical community. So if that's the amount of money, the amount of FTEs, and we know what the penetration is that we're reaching in our community, is anyone better off? And what are we seeing for outcomes in this very short period of time? OneCare Vermont just released the 2018 Quality Measure Report over the last month, so we've taken some time to digest that. For you today, we've selected 4 areas that we wanted to directly attribute to the care coordination work. The first one being screening, brief intervention, and navigation to services. This is directly related to the screening for depression and the follow-up plan. So we know across Medicare, Medicaid, and the commercial insurance that we are exceeding the OneCare Vermont benchmark. The second one is transitions of care, medication reconciliation post-discharge. This is a Medicare benchmark for the quality metrics, and we are exceeding that. The next one's around chronic disease care management, and specifically around diabetics and poor control. We know that this measure is for the Medicaid and the commercial population, and we have identified that there is opportunity for us to focus on in the coming year. The last one is Medicare, the annual health risk assessment that's specific to the DMI measurement for our Medicare populations. And again, for this one, we are exceeding that benchmark. There are 3 key opportunities that we want to highlight for you today. The first one being that as much work as we have done over the last 10 years to begin aligning the quality measurements back federally at a state level and within our communities, there's more work to be done. Across the populations, we're looking at different type of measures, and we can really start to streamline that even more in the coming years. Taking those very precious, valuable resources that we have, and really being very deliberate in what we want to see for change in health, population health outcomes. The second one is around looking at whole population data. What we tend to do is look at the attributed lives and what has changed and what hasn't changed. We know in our practices, and we can speak to this clinically, is that we serve who comes to our door. We know for the calculations for payment and such that we have to look at the attributed lives, but it's very, very important for everybody to know and understand that we serve the patient needs to come to the door, but the amount of funding and the resources for these types of things are very limited, and really prevents us from being able to do more than what we want. Performance assessed on sampling data. This is the last piece. Data. The more that we have, the better we can make decisions about how to spend these valuable resources. So real-time data. We know that these quality reports are 1 year in arrears. It's very difficult for us to course correct and reallocate much of these resources if we're knowing about our data too late in the game. So looking at all population data, moving away from sample data, and having it be more timely and assessed. You can see from the number of N's here that we know there's about 7,000 people in our attributed model right now under the Allpayer Model, and this is very few numbers that we're able to assess our progress on. So it's very important that we really turn the curve on our data. So all of this work in prevention and well-being, lifestyle medicine, Rise Vermont, all of these strategies are crucial within a capitated model. We know that we have to systematically value prevention and well-being just as we have medicine and disease under a fee-for-service model. If we don't do that, we're not going to be keeping pace with the clinical redesign of our systems and the way that we're getting paid. True transformation of payment and reimbursement, again, in parallel with clinical systems redesign, will allow us to position us really well to achieve new population health outcomes. Many of the things listed here you heard in the previous presentations as well, but I would like to highlight before I pass it on to our CFO is that transformation of primary care and truly building team-based care will be what helps us to increase our access to primary care. It's very complex, and distributing the complexity of that care to the right people on the team at the right time will be what helps us build greater access, and will help people to attract them, medical professionals, to choosing family medicine and internal medicine in the future. So I will pass it over to our CFO, Robin Albans.
Bye, love you.
I want to knock myself out with the microphone, so we'll put it right there. I am about 2 months into this position. I think I joined at just a great time. My first introduction to you guys was in our budget presentation, and so now it's queued up for me to find a way to ask for even more money. I think my colleagues have done a great job, really, of telling the story of our early adoption into the goals of the Green Mountain Care Board, goals of the state of Vermont around health, wellness, and moving to a value-based system as opposed to fee-for-service. Some of those things we've already talked about. We've shared with you the business plan that we embarked upon to fire start the movement with Rise Vermont in our communities to set ourselves up for success around changing behavior. My colleagues have done a great job of showing that that worked, and it does work. All of that effort and coordination and changing of culture, of adding resources, we had to add resources that aren't present in a traditional fee-for-service model. And we were fortunate through good stewardship, through meeting the needs of our community, that we had a surplus. We had days cash on hand available to make this investment because we were all in from day one. but that has changed. We've reached now, obviously, the goal of being low utilization and low cost, but our reimbursement hasn't caught up in terms of attributed lives. You can see all of the resources that my colleagues did such a great job of outlining continue to fall significantly short because we still live primarily in a fee-for-service environment. I had a conversation walking back from one of our tours that this almost would have been easier if we had just ripped the Band-Aid off and converted 100%. I'm meeting later on tonight with some of my physician leaders and medical directors. We're trying to crack the nut on what compensation is going to look like. We know we have issues in recruitment and retention. We continue to focus on our operational improvement plan. Some of this you saw in our budget presentation. $6 million in sustainable savings. We've identified another $500,000. We continue to do the work. But, and I'll use the Southern colloquialism, there's just no blood left in the turnip if we're still going to be able to, I'm from Alabama. We're just not going to be able to keep making that level of investment and being that partner from day one if we're continued to be held in a one-size-fits-all budgeting approach. One of the things that I think is very clear, and again, I think anecdotally, my colleagues set me up to talk about the investment in the physician practice and that growth rate. We had one of the questions in our budget and fence was how much of it was related to physician salaries. Well, we know some physician salaries have increased because we have a shortage. There's more demand for certain there's more demand period than supply. But certainly in primary care and pediatrics, the demand is even much higher at a time when also the demands of them as practitioners is changing. On our tour earlier today, Dr. Fingergut talked about, she doesn't get to spend as much time on wellness and prevention because our population's aging. We're still dealing with the impact of treating disease or managing disease instead of prevention. And those patients are requiring more and more of her time, and she's having to give up and refer out parts of her practice that previously a primary care provider could perform, such as partnering with the family to try and improve health. One of the things that I think it's important to realize that for organizations that are showing the payoff, we're showing that our utilization has decreased, we're showing that our costs have decreased, the one-size-fits-all budgeting approach doesn't work for those institutions. I think you see that. It doesn't work for us. We've got to look at different levers. We can't continue to invest in our communities if our per member per month payments can't catch up. They're not front-loaded. We're still at around 30% of capitation, but 70% we have to rely on fee-for-service. And the problem for that is as utilization goes down, we've lost some of our subsidy out of our private insured market. That is a huge gap that we cannot overcome and to be financially viable. So one of the things that I think is important, and I appreciate you guys coming today to talk with us about is it is time to course correct. It is time to look at those hospitals, those communities that have partnered, that are showing the results, to consider how can we really help them bear the burden of those costs until we see greater growth in our capitated lives. We talked about recruitment, we talked about wage inflation costs. Tonight I've got to figure out with my specialty care, how can I keep the specialists that we need locally when their utilization is declining, when work RVUs is no longer really the right measure. There's no roadmap for that, just like there's no roadmap for us in the state of Vermont of how we're going to get here. We're having to blaze a trail. And when you blaze a trail, you have to sometimes turn back go around, up, or over if you can't go through. And I think that we're there. We have done all that we can to position ourselves for success as an organization, as a community or service area in a value-based all-payer model. But the finances have got to catch up with us. So what are some of the things that I think we should be talking about? And my team, we talk about this on a daily basis. Our physicians are becoming more engaged. You know, I hear every day that they're burned out, that the demands and taking care of patients, we can't wrap around them quickly enough or with enough resources to provide the level of care. While very high, we're just at the tip of the iceberg. We're 30% capitation, and we already have a provider group that, you know, that we need to expand, that already is feeling a loss of part of their practice in terms of an aging population. As we grow in capitation, those factors are only going to be exacerbated. So what are the things that we can look at? I mean, part of it is, and I appreciate Chairman Mullen, your letter to the legislature about tapping into the DSR funds. I mean, to me, it's, you know, it's like a 401k approach. You know, if your employer is going to match your investment dollar for dollar, you're leaving money on the table if you don't take advantage of it. So how could we look at a strategy of tapping into the DSR funds that helps subsidize this investment in primary care until the per member per month payments catch up, or the level of capitation makes it a much more balanced revenue field for us to then appropriately spend and invest in long term. Some of the other things from a legislative standpoint, you know, how can we wrap around OneCare Vermont and help them move the needle in terms of capitated lives? What can be done to help reduce some of our costs around equipment, drugs? Those costs continue to climb, and we, while we've expanded our participation in the 340B, you know, one of our VPs, Joel, has done a great job. We're on pace to exceed the savings that we had initially anticipated. Other things that could help is just in terms of time and reporting and administrative. You know, I know being, you know, in a data analytics type person, and from an accounting standpoint, that it's much easier if you have everything coming in to evaluate in a standard model, but you've got every institution's different, they have different accounting systems, etc. We want to be engaged from a time and effort commitment to come to Montpelier for these meetings, but that's a half a day most every week of lost productivity times several of our key leaders. So is there an opportunity to live stream, to maybe know the topics more in advance so that we can plan and have just the right number of people at the right time to participate in these meetings? The other thing that we know that is of concern and part of our budget order is a sustainability plan. And I think it's important that, you know, these issues are going to be part of that sustainability plan. We can't get blood out of the turnip. And so we do need help. I think one thing too, when you talk about, and before I hand it over to Jill, when you talk about partnerships, I think as an institution and a community, we've done a great job trying to partner where it made sense with tertiary centers, with UVM, but they're experiencing the same issues around recruitment and retention. We've had a long-term relationship with UVM around our cardiology, and now we're at risk for not having that solution to our community because we did rely on our larger partner who's experiencing the same recruiting dilemma. So again, I don't think that that's the be-all, end-all in terms of partnerships. We have to realize what risks also come with partnering in those ways. So thank you for your time, and I will turn it over to Jill to conclude.
Great, thank you.
When you think about partnerships, it's a lot about showing up. And as we started our conversation, seeing this room full, it has taken a partnership across this entire community that is totally engaged in the path of our population to better health. But it's crazy complex and it's challenging, and there's so much work because in the middle of how we're trying to figure out how to do it better, we're really caring for patients first and foremost. And everything we do, our quality program is around patient first and high reliability. And it's really about, we think about cultural transformation on the community. It's an internal transformation, it's a statewide transformation. And how are we going to lead this together? And so when you think about partnerships, it's about how do we come together and not only facilitate conversations within our own community, but more so around the state. I don't know about you, but 2022 is coming really fast. And when we think about the covered lives and being 30%, and we're 30% in 2020, I don't know about you, but that's only 2 years. And how are we gonna figure this out? I mean, so we can only do that by stopping and checking in and bringing the stakeholders, bringing the Green Mountain Care Board together, the VAS, the OneCare Vermont, Blue Cross, obviously the hospitals, and the stakeholders, legislators, and really we've got to sit down and have a conversation about the direction that we want to take this, because we all have our purposes in this. And just like this organization, just like this community, we can no longer operate in silos. It's really about integration, and integration doesn't mean corporation. That's not another word for that. But it's really integration in the behalf of our patients that we're serving, and they're Vermonters that are really relying on us to figure it out. And I think it's time to take a pause and come back to the table. The complication of the patient, I mean, I don't know what the ED looked like when we went through it today. It might have been really calm, but on many days and most days, it's quite chaotic. And the work that they're doing is remarkable, and certainly across every system as we're trying to figure out how to do things differently. The medical record, you probably felt that in primary care and in pediatrics. We gotta stop and take a breath, because we're losing the providers that we need to have engaged in this future forward. So integration takes time. And Northwestern Medical Center is at a different place. Yes, we still have money in the bank, but operationally, as you have seen, we're in a challenging spot financially. And I did read the social media as well that says, if you're why are you investing in the emergency department? I thought your financial position was being challenged. Both of those answers are right on, both of those perspectives. But we need to invest in this future. We need to invest in how we're going to care for the behaviorally challenged patient as we wrap around it, as we try to think about things taking time to get the right system in place across the state to care for these patients. There is tremendous work going on all over the place, but it takes time. And in the meantime, we have people that need us, we have people that are aging, and we are people that need our emergency services in a place that is confidential, that's private, and that staff are safe and patients are safe, and the access to care is appropriate in that moment. So it's time that we do invest, and we did prepare for this financially for this investment along our journey. Addressing social determinants, and I think about these health coaches, or I think about the primary care providers that are really getting into what's happening with our patients. And you can prescribe them medication, but if they don't have transportation or they don't have the funds, we have to get inside these social determinants, and then we're having housing conversations, and the hospital and my partners in this room in the community are talking about those conversations. At the same time, we've got to transform the healthcare delivery system. It takes time. We do need the latitude to lead and to move forward. I'm hoping as you feel this community in this room and the things that you've seen today and you've felt over the many years, that this is a community that is totally engaged for the transformation. But we do need the latitude to lead, and we do need also the financial sustainability and security in order to continue to lead. Because the one thing that we do believe locally and as a state, that we are moving in the right direction. But we do need to check in, figure out where we're at, take a look at what our priorities are, and also align the incentives. both locally and across the state. So changing the culture for health and well-being is really where we need to go. But it's a room like this that makes us all convinced that we can make it happen in the state of Vermont. So again, thank you for being here. You've been here a whole day to invest your time and energy here. We greatly appreciate that. And my colleagues, not only inside this organization, but across this community and the state, thank you for being here and being part of this conversation. So let's come together. Let's look at our roles and redefine it. If we want our healthcare to be different, we have to be different and be willing to trust, to partner, and take the time necessary to make the right decision for the people that are entrusting their care to us, Vermonters. Thank you.
Thank you, Jill. So with that, Jill, I'm sure that you're willing to take any questions, right?
Oh, I think we're done. Just kidding. Everybody else was telling me now I had to do so. He would be happy to.
So board members, we'll start with the board. You want to start, Robin?
Sure. Jill, thank you. On the issue of increasing scale or number of folks in the capitated system, I was curious to know if you have ideas for your community about what might make the difference. Because of course it could be either, for some communities, it's not all primary care folks have joined OneCare. Other communities, it's more driven by commercial insurers not joining. I was just curious for your community, do you know which of those is really driving that?
Yeah.
And if you don't, that's fine. I was just curious, if you've thought about, in terms of us all coming together to work on that, I think we have to understand what's driving it.
Sure. I'll speak to that really briefly, Robin, thank you. Is that in Franklin and Grand Isle County, as you've known historically, it's been a highly engaged and one of the front runners. So we have, I think there's only 2 private practitioners that are not participating in the Allpayer model at this point. So all of pediatrics, I would say better than 80 to 85% of primary care are under the Allpayer model. So unlike other communities, we are a highly engaged group.
Yeah, so it sounds like really the issue is more in the commercial space, self-insured employers and
absolutely
in that sort of area where that's kind of the missing piece.
Yeah, which we have some of those in this community, but not to the extent that other communities are experiencing.
Yeah, okay, thank you.
So I'd like to go back to a discussion that we had this morning in terms of alignment. There's some global issues here that I think you've touched upon in terms of Medicaid, paying a higher share of its costs, covering its cost, issues of payer mix. You're, as in my view, a kind of a disadvantage on both of those relative to other hospitals that can have a Medicaid population, but shift some of that burden onto their commercial payers. But we had I thought, a good discussion this morning just about aligning the commercial insurance plans with the Allpayer model, basically. And one example was prediabetes. It seems to me, if you look at least the silver plan and the gold plan for Blue Cross Blue Shield, that the only benefit that exists for prediabetes is the prevention visit, which will tell you whether or not you're prediabetic. But then there's no other benefit beyond that, other than I think it's up to 3 nutritional visits at a copay of $50 to $100, depending on whether you have a silver or gold plan. But then when you cross that line and you become diabetic, according to Blue Cross Blue Shield's marketing information on their various plans, it's a $7,400 a year expense to deal with somebody in a well-controlled diabetic situation. And so that doesn't make sense to me that, where you have basically a cliff, and there's a lot of cliffs here in terms of the premiums for some folks, but here is a cliff where if the insurance policy was better aligned with what you're trying to do, then you would be getting some help avoiding people from crossing that line on a from pre-diabetic to diabetic. So I think that's something that we need to work on in our review of rate in our rate setting. In our rate review process. I always say rate setting, but some of my peers tell me it's a rate review. We don't set rates, but we certainly have some influence there. And so for me, advocating for a fair share in the legislature for Medicaid, you can look at the OneCare budget this year, and so far in that process, they're looking at 0.5% as an increase in the Medicaid share. That's not sufficient, and I think that's been happening over time. Looking at possible ways to restructure the payer mix, the federal government has a structure for its payer mix in terms of Medicaid. States that have higher, weaker employment statistics, those states get a higher share of Medicaid share than others. Why can't we do that at the state level to try to kind of spread that limited resource in a fairer way, but also just aligning insurance policies with the goals of the Allpayer model.
Well, and you saw in our data, and you actually asked about that cohort of people in pre-diabetes, and only 19 folks took us up on the referral from primary care and the health coaches to see the diabetes educators, etc. If they knew that it was affordable to them and it was part of their health plan and it was just all part of it, would more of them taken up on that? I think you've got foundational data here that somebody's got to invest in up front and make those things, but you can leverage those study-proven savings. And so I think there's a real discussion to be had with the insurers and with Vermont Care Board and the legislature, et cetera, on turning that ship so there is that alignment, so that people do feel they have access to the preventive services and providers are comfortable sending folks in that direction, knowing that their people will be able to afford it.
Well, I think exploring the leverage there is important. I mean, if you look at the Department of Public Health data on pre-diabetics, it's a huge population. We're not talking about a small corner of the morbidity world. We're talking about a large piece of it. And if we can restructure how funds flow more favorably toward avoiding diabetes than to pay for diabetes, it's certainly a better use of resources.
We are so motivated in the past of being very traditional, and our monies are all about treating the sick. And so how do we take a portion of that money to prevent the sickness? It's not like we have to die of a disease or have a disease, and how do we prevent that? The hospital has invested in health coaching for their employees, and Blue Cross came to our table and said, gave us their report, and they said there's something different going on here. And what they have deducted is the fact that we are offering health coaching and incentivize our employees to get that health coaching so we can catch them early. And they're seeing a difference in translating that into dollars of cost of health premiums. So it's a good time to have that conversation because the data is showing the impact.
I just wanted to follow up on that because what I wanted to mention is that this community is out in front. And I think back, I think the second traveling board meeting that I was on, we went to a community that was so proud of showing the wound treatment center to us. And they kept talking about how many dollars they were saving by not having to do amputations because of that wound treatment center. And when I asked the question of the doctor, yes, but what's being done in the primary care practices out in your community to try to, start counseling somebody when they are pre-diabetic so that they never even end up into your wound center? the eyes kind of glazed over. And so in that short period of time, in just a couple of years, it's so refreshing to sit in a room with people that understand where the real savings are in the system. It's by keeping people well, keeping people healthy. So I just want to commend this community because you are out in front, and at times it may not seem like it, but you're doing a good job.
First, I want to thank you for the meetings that we had today and, really getting exposure out in the community because you can really see that passion about, everybody really coming together to try to get prevention to work. And so the question I have is really around, you've talked a lot about opportunities and threats that you have in order to accomplish this. And, if you were to pick what the top 2 opportunities and threats were in that, and I also want to preface that though on saying that, I understand there's potential asks for additional money or looking at the caps that we have and maybe making some exceptions on that. And for the past, for the 2-year outlook, we gave kind of the 3.5% target that, really goes with the total cost of care. And, so in order to get around that and to go higher, that would also be difficult in this whole system where we're trying to reach that 3.5% growth rate. So, I don't know what the right answer is to say, how do you get more funding in here? But we did give, fairly high commercial increase this past year, and assuming that we can't get any payer shift, right, which I know Tom has addressed, right, any additional increase goes to the consumer who's paying those commercial rates. And that's kind of one piece that's missing in this puzzle. It's just saying it's not just all about the health and well-being. One of the things we hear about that's impacting these patients is they're saying they can't afford the care. So they're paying 20% of their income to pay their premiums, and then they can't afford to pay on top of that their deductibles and everything else, so they're not going to care. So we have this pressure of saying we may need more in order for it to work, but right now that more tends to be coming from the commercial payer, and those commercial payers can't afford to get the care that they need because they can't pay their deductibles. They pay their premiums. So, within those parameters and frameworks, what do we do, right? And so, I want to now throw it to say, what are those 2 opportunities or threats that you think are really pressuring on your system, but how could we manage those without putting increased financial pressure on the consumers, right? And even if it goes to Medicaid or Medicare, however, it still comes back to everybody paying that. And if people aren't getting care that they need because they can't afford to, that's a big barrier as well that is challenging us.
So the question is, what can we do within the constraints of what we have, correct? Because there's not monies coming from additional opportunities to shift other resources. And
I think if you had to live within those constraints, what could you do? And, we know this hospital in particular had some other challenges, right, with your medical record system coming in, and that really brought a drain on your operations. But it wasn't necessarily specific to what's going on with the Allpayer model, right? We have some other issues that you need help to get out of, and we did give you a higher increase this past year. So just trying to figure out, what do we do? And I know there's no answer, right? But everybody, when we meet with them, would like more to help with the problem. And at some point, there should be a payback on that. And we know it's kind of down the road because it takes so long to get these prevention policies working. But I just wanted to ask, what are the couple threats, opportunities?
Sort of ask almost the impossible. But so when you think about, we say, well, we want more for, more latitude with our revenue cap, but really, then we're chasing that dollar, that sort of that fee-for-service dollar almost to get that revenue cap. So, without those revenues, though, we can't afford the rising cost of the expenses that are continuing to plague our organization. So as our revenues come down, our expenses are still going up. And so we are scrambling, trying to right-size the organization, and how do we step back and strategically, locally as a community, of having the opportunity. So we're always worried about this bottom line, and and now our accountability and our financial sustainability, when we really need to be sitting down, with our partners to figure out what does integration across this community look like. I mean, we all have medical records, we all have HR, IT, or whatever their resources, and so it feels like we're scrambling to get to the end so fast that we have to take the time to build these relationships and these integration strategies that can work long term. So the biggest threat is keeping an eye on the ball of this organization financially and recognizing that hospitals are bearing the risk of this model. And so if we're going to bear the risk, then we should have the latitude and the ability to really drive the conversation of what needs to happen, across the state and locally. Because there's so much pressure on hospitals of reducing cost and fueling the future. So I think our biggest risk, is certainly, financial sustainability during this transformation. Also, the pressure that's putting it on the workforce. Obviously, it's hard to recruit, but I worry about the providers that are in this room trying to still take care of the patient. And navigate an electronic health record and just try to work at almost lightning speed for all of these things or regulations or this transformation when they want to take care of patients, and that's what we're meant to do in the first place. So I think the financial sustainability through this transformation, we want to continue to lead. So that's an opportunity for us to continue to lead. I think we're doing the right things. We're investing in the right things, but our board is asking the right questions. How long and how much can we continue to do this? So I'd say our providers and recruiting top talent in order to navigate this future with the pride and passion that they went into the profession with, and our financial sustainability. And the opportunities sit in this room, which is the engagement of this community to integrate for the best transitions of care for this community and positioning ourselves in the future. And in the gap of that is how do you finance it?
Thanks.
I don't know if that's and I asked my peers to jump in on this because we're all feeling it and working it in the real world.
I would like to just add, we talked about the cost shift to the consumer. I think it's absolutely right. We talked about how the incentives, even within a health insurance plan, aren't there. That if you have diabetes, you can go and get treatment cheaper than you can take advantage of the preventative things. So I think the pool can remain the same, but we have to have those conversations with the payers, with employers, and what can be done at the state level to help legislate some of those changes based on evidential data that it does work. So if Blue Cross, if you will, or this employer would approve a change to their plan to pay for nutritional counseling, and now you've saved yourself $7,400, then let's share, how do we share those cost savings to pay for that locally? We don't have to have all of that, it can stay, but I think the pool, when we say more, that probably isn't the right way. I think it's time to sit and look at where and how it's being spent, and is that aligned with the behavior that needs to change and how our plans are structured, cost shift, and recognizing that we can't keep putting the cost of care on the patient.
I think that's a good way to frame it, is, how do we shift some of that?
One of the other things that I'll add is a big portion of those commercial rate increases were directly related to pharmaceutical cost.
Yes.
And I think the conversation as we approach the legislative session this time around is very important to talk about what Vermont's approach is to pharmaceutical cost and the burden, as Jill said, on the hospital systems as well as others to support that. And again, I would like to stress that prevention and well-being and the work that we're doing with Rise Vermont and Lifestyle Medicine is with the intent to reduce the need for pharmacy and medicine long-term. So there are other strategies and conversations that should be happening in that area in particular.
And as Amy takes that to a big legislative level, I'd take it a step farther, even Vermont legislators involved in it, but the national legislature. We think of Vermont as $1.2 billion with a healthcare system. Big Tobacco spends $9.5 billion a year just in advertising, not in production, not in anything else, just in advertising to keep people smoking. And so at a policy level, not at your table, and probably not so much at the Vermont table, but we do have some levers to pull. But this is a societal shift, and there's money in the system, but it might be over in Big Tobacco. And we might need to go back to them and say, the settlement's not enough, we gotta keep going.
So thank you all for this morning and as well as this great presentation. And I want to empathize. I think this is a really hard time to be in hospital delivery, and I think to be in healthcare and trying to figure this out. You've got pharmaceutical drug prices rising. We don't, in Little Vermont, have a lot of control over that. Technology just costs in general are causing healthcare costs to rise. We've got a workforce shortage that's causing major wage pressures that's national, not just Vermont. So we're living in a world with a lot of external cost pressures that are coming down on us here in Vermont. At a time when people, as my colleague here said, it's really harder and harder for people to afford health insurance and health care in general. At the same time, we're asking hospitals to completely transform how they deliver health care. And we're asking them to do that in this very challenging climate. And I think we all recognize that, and we're trying to find a way forward and trying to think about how we can create the right incentives so that hospitals are making these investments in prevention and in primary care and taking care of their patients in high quality ways. Until we get to scale, where we really are under capitation or fixed payment, it's going to be really challenging and difficult. And so I appreciate the frustrations here. I think we often feel this way too. I want to ask a little bit about, Robin, I think I'm going to ask you in particular because you were the one that, you mentioned the challenges of the budget process that has a one-size-fits-all approach. Mm-hmm. And I wanted to ask you to elaborate a little bit on some of the levers to the extent that right now the way we think about the hospital budgets is through net patient revenue, right? And that's how the caps that you referred to. And I think there are many challenges and problems there, and I mean, as population changes, that doesn't adjust, right? So one way to fix that is to do more of a total cost of care per capita approach. You'd have to adjust for payer mix. You'd have to adjust for risk in the community. But if you risk adjusted, payer mix adjusted, and went with a total cost of care per capita approach, that would certainly be more aligned with the Allpayer model of trying to reduce, the costs per person of delivering care. It would incentivize delivering the right care at the right place at the right time. If we could actually get that right, we would want to also make sure that we're accounting for quality, right? So making sure that at the same time that we're looking at total cost of care per capita, risk adjusted, payer adjusted, we're also having some metrics that say, hey, you're doing that, you're delivering that care efficiently, and there are high quality outcomes emerging from your community. And the third bucket is access, and the people in your community have access. So given if those are sort of lofty goals of how we want to make sure that the hospital systems are doing what we hope and believe that they are doing, what would be the metrics, the levers that you would say if you had the opportunity to reimagine the hospital budget process here by the Vermont Care Board, thinking about those things, how would you do it?
Oh, I think you're headed down the right path. I mean, one of my slides, and I started to get nervous, so I started talking faster, but was about the growth in physician care and those support services. So in this bridge period, if you will, do there need to be carve-out considerations for that? So if you're evidencing that your costs are going down and your utilization is going down, your capitated model it hasn't bridged the gap of what's needed to achieve that result. Does that need to be a carve out outside of it? And I think Stephanie did a great job sort of showing where we're looking to increase our rates was on the hospital side. We're trying to keep the ambulatory side flat. We don't want to pass on more to our patients who already are struggling to pay. We're looking at how we can convert more bad debt to charity care. What grants might be available to us, even though we have an FQHC on site. So I do think when I say not once, I think it's just time to rethink how the pie is divvied up. And reward those who are showing evidence more in alignment with where we want to be at the end of 5 years. than not.
So specifically, how do we reward? What is the actual reward how would we do that? How do we implement that?
Well, I think having, decide on the metrics, so if it's access, if it's quality, and then to just look at the cost and, then, that's the hard part, is then to debate, well, what should be included, what shouldn't be included. And we're having the same conversation in our physician because we can't look at work RVUs anymore. I can't, look at a primary care provider and say it's X number of RVUs. I can't even really, I think, you asked the question, in an ideal day, how many patients would you see? Well, it depends, because I'm not going to deny care to someone that presents in my office. But I think it is that redesigning and re-divvying up of the pool and recognizing what are we investing in that needs to be subsidized, and can we do that for some period of time until we're at, 75, 80% or 100% capitation.
Got it. Okay. Thank you.
So I'll stand up because at this point in the meeting, we open it up to the public for any comments or questions. So if you could just raise your hand and I'll deliver the mic to you if anybody would like to. You don't feel obligated, but.
Thank you. I'm Marissa Parisi. I'm the director of Rise Vermont statewide, and I felt like I had to stand up to recognize this community for their work on Rise Vermont. It's really an honor to lead the work expanding Rise Vermont, and I'm sitting next to Jessica Frost and Amy Burr. And are there any other Rise Vermonters from up here? Oh, and Wayne Goodrich, of course, our Rise Vermont board member. And I want to say, particularly to the member Pelham, they have a video of me dancing in the St. Albans School District as well. And it wasn't pretty, but I got my heart rate up. And they did use that video again, so it's not gone.
Why did you assume this wasn't pretty?
I think Denise supplied that, not me. The Monster Mash isn't a good look on anyone. So I want to say just two things about this community as well, is that first, thank you to the board, because I know we just got through budget season for the hospitals, and just thank you for giving hospitals the latitude to budget for prevention, because Jill and her team here, they put a lot into prevention at a very, very hard time, as we've acknowledged, for hospitals. And focusing on that prevention makes St. Albans and the communities that Rise Vermont is in an incredible place to live. And I just want to I know we're all focused on healthcare and people's wellness. What the work of Rise Vermont and hospitals do for economic development can't be overlooked. I mean, what an amazing time to live in St. Albans. You have a world-class wellness program that's embedded in your communities, that works closely with the businesses here, where the hospital cares so deeply about your care. So when we budget for prevention and we help get all communities, Rise Vermont, to the point it is here in St. Albans and in the Franklin-Grandal communities, we are doing a lot more for Vermont than just taking care of people's wellness. We're really taking care of the whole state. So I just want to thank you for allowing the hospitals to budget for that program.
Thank you, Marissa. I will tell you, though, that we're all disappointed with Rise Vermont today because we really expected that we wouldn't be able to ride the bike.
Give us 10 minutes.
Does anyone else have any comments or questions? Glenn?
Yeah, hi, Lynn Dickinson. I want to thank you all for coming here. This is really exciting. I served on the POC for Bishka for 5 years, so I understand. They paid us $50 a day and free lunch at the Capitol Plaza in those days. I really want to say that the opportunities for improvement and the effort to do Rise Vermont and to work on wellness is really important, and has really created an awareness in the community. When we want to align incentives for people to be well, about 20-something years ago, we created a couple of changes in our healthcare policy for insurance companies. We created community rating and guaranteed issue. Guaranteed issue, of course, is handling pre-existing conditions. I won't get into that right now, but community rating was a major change and did raise insurance costs for a lot of people. And it's been changed a little bit under the ACA, but not as much as Vermont had. This is where you charge the same rate regardless of age or health condition. Is this counterproductive or something that needs to be reviewed with what we're trying to do with creating more wellness? I mean, as people get sicker, should they pay more for insurance versus people who stay healthier longer?
So I don't think that there's one simple answer to that, and I think we would probably have 5 different answers for you. And basically, as someone who remembers the days when I could buy a policy from, I think it was Liberty Mutual at the time. But in any event, it was dirt cheap. But it was unfair that, in some respects, I was able to buy a policy for, and this is really going to date me, for $200 when it was $500 for the female coworker with me because she could get pregnant. So I think Vermont went through a huge debate on community rating. I would like to think that that debate is over, but I think you're going to see that again because I think there will be a policy discussion on reinsurance, and on that policy discussion on reinsurance, does that mean that you would then divide up the individual and the small group market? And so as much as many of us think that the conversation was in the past, I think it's going to continue. And I have to tell the story. A gentleman called into the radio station and he had found a pamphlet from 1931, and it was the hot political discussions of the day in 1931. And it was how to pay for healthcare, how to pay for education, all the same things that you're dealing with today. They don't ever truly go away. All we can do is try to, create more efficiencies and try to do better than what we've done in the past. So.
Kevin, can I just add one thing?
Sure.
I just think it's important when you're thinking about insurance changes to take a step back and look at where Vermonters get their insurance coverage today, because we have very few people in the commercially insured market. We have about not quite 80,000 in the QHP or the qualified health plan market, and less than 20,000 in large groups. So most Vermonters are not in that market. So the changes that legislators are able to make don't impact the self-insured employers, which is where the bulk of the commercial market is today. So I won't comment specifically on community rating. That doesn't apply to self-insured employer plans or the large group, just the Vermont Health Connect population. But I think it is important to kind of take a step back and see, where does everybody get their coverage today, and are we making, who are we making the impact on, and who isn't impacted by this change? Just so that you really understand where your levers are.
Thanks. Anyone else?
Thank you. Liz Gamache, member of the Board of Incorporators and resident here in St. Albans.
Are you still the mayor?
No, I didn't run for a 4th term. Just a citizen. But I wanted to extend a thank you to you, Chairman Mullen, for sending a letter on behalf of the board to the governor several weeks ago. I thought it was well written and outlined the issues that we're facing as we move to the capitated model in a very understandable way for us laypersons. This is tough stuff to digest. So thank you for doing that. I think it helped to incite deeper conversation amongst regular folks, and I appreciate that. It helps us to understand the challenges and why it's so important. Over these last few years, we, as you know, as you're seeing, we're so proud of what is happening here. The passion that we have, the belief in this movement is so strong. And as Marissa said, because it goes so far beyond just what we might have thought in the past of healthcare, so far beyond physical well-being to social, to mental well-being, to economic and environmental well-being of a community. So the ripple effect, the multiplier effect, we're feeling it, it matters. So we really, I really want to see this work, and figuring out these challenges that come as we go through this transformation is so important. So thank you for your leadership on this.
You're welcome. It's great that so many legislators were here to hear that. Anybody else like to say something? Jeff?
I'm Jeff Tiemann with the Hospital Association, and I really just want to say thanks to Jill Barry-Bowen, because when I got here to Vermont 3 years ago, I was starting to learn about something called Rise Vermont, and it was in a few hospitals, but not very many, and it was still in its infancy, I think. And to her great credit, Rise Vermont is now almost statewide and integrated very thoughtfully into OneCare. And I think that is all because of Jill's sort of tenacity and her desire to make sure that we're treating our population in a whole sort of round the dial kind of way. And so I think Jill deserves a lot of credit for that. I myself was skeptical, and it's been amazing to watch kind of how her leadership has moved the needle on that. So, and I also want to thank the board for having this meeting here, and I want acknowledgement that I usually stand up to complain and I'm not doing it.
We truly appreciate that. Anyone else? If not, then
There's one here.
A couple of quick comments. So I'm Monica Green. I'm a local employer based in Swanton. I have a long-term relationship with the hospital. We've been located in Swanton for 50 years. But I will say, since the combination of the hospital and Rise Vermont, our health and wellness program has grown tremendously, both in what we offer and how often we do. And it is kind of interesting, we're self-insured. We have about 250 people here and another 125 out of state. So we shop every year. And as we did this year, it's kind of interesting that we have multiple plans, something similar to a gold, silver, and bronze. But what we don't hear about when we're shopping or creating our self-insured plans is the option for the, like the pre-diabetes, the health and education. So it's interesting that we pay the hospital for, we contract for wellness services, then we go back to our insurance company to see if they can incentivize the health insurance, when in fact what they could provide us in the insurance programs, the benefit, the schedule of benefits that they offer, could have also helped or assisted. So there's a
be the first year where there are going to be some solid inroads into commercial insurance through the Allpayer model. And I can't get into the budget for the Allpayer model because we have our attorney here. Cool. But I can tell you that there's going to be a big uptick in the number of lives that will be participating through the model, and hopefully some of the things that you're already doing, some of the other businesses around the state are going to see that being funneled through to them through their employers' participation in the Allpayer model. So it's encouraging to see. It's a little bit late. We wished it happened a year ago, but we're really happy that it is happening. So yes.
Hi, Joanne Manahan. I'm a nurse manager of the ER here, but I'd just like to say that I think it's more than just financial benefits and physical benefits. We talked earlier today about our mental health patients in our ER, and I think if we start with physical health, that is how we start, but the more people feel healthy, then the better effect it's going to be on their overall well-being and maybe help prevent some psychiatric issues.
Absolutely. Anyone else? Who am I missing? Seeing none, I just want to really thank the community for the turnout today. And we'll quickly do a couple of things that should take 1 second. Is there any old business to come before the board? Seeing none, is there any new business to come before the board? Seeing none, is there a motion to adjourn?
So moved.
Second?
It's been moved and seconded to adjourn. All those in favor signify by saying aye.
Aye.
Thank you again, everyone. Have a great rest of your day.
Thank you.